Okay, so today we are going to talk a little bit about what I do as an orthodontist to help a lot of the patient that I see in my office of different ages. One of the things that I think is so important for us as a provider, at least in my opinion, is to help pediatric airway. The reason is they cannot help themselves. I have a 10-year-old and I have a 4-year-old. And a lot of time, those patients, they won't know that they have a narrow jaw. They won't know they have airway problem. As parents, we need to recognize the symptoms and the signs that our kids have and bring it to the attention of the providers. If I was an orthodontist or a dentist, a lot of YouTube and TikTok video that I do, I teach people the sign and symptom of airway. That way, at least when they go to their pediatric dentist or their general dentist, they can bring up like, "Hey, I the bar said this on his video that these are signs of airway. Can you please screen them for the airway?" So I think pediatric airway is something that I'm real passionate about, and we really need to educate and improve the airway in our children because they cannot help themselves. And if we do that as a whole, as a profession, I really don't think we can really eliminate the need for MARPs and surgery. I do a lot of MARP and I do a lot of surgery. I'll share a couple of cases with you. With that being said, you can do it. It's better for you to prevent it altogether. So let's talk about MARP in this presentation. MARP stand for mini implants assisted rapid expansion. You can also hear a term like MASPE, which is MASPE. That just mean a slow expansion protocol versus a rapid expansion protocol. Usually the rapid protocol is maybe one turn a day. And depending on what kind of screw you use, that's really about 0.16 millimeters per turn, and they call that rapid. The regular RPE is a quarter of a millimeter per turn. The mass P, you tend to churn it maybe once every 3 or 4 days. So you're looking at maybe a little bit slower churning. So if you hear the term mass speed, that's what that. And then the term on the bottom, which is rapid expansion, that's really popular among phase one or early intercepted treatment that I do. And those are mostly on kids where their suture is still open and you don't need any mini implants. So that one will be just the RPE without the MA. Okay. This is a patient. This is strongly recommend if you guys see patient like these in your office to get them treatment right away. This is a child who have a narrow palate. You can see he has an ectopic canine, rotated canine here on the left side that is severely rotated, classic narrow palate. We did a rapid patho expander on him, which is an RPE, and you can see he has just the arm with a regular screw with no mini implant. So very, very straightforward, very easy. There's literally no pain when you do the expansion. The kid just feels some pressure. You can see we get some nice suture opening without any dental tipping of the teeth. You have a nice diastema here that's starting to open. So this is a true skeletal expansion and not really a dental tipping. So this is really straightforward if you catch it early enough and help the child out. Okay. So this is another case. This is Sam. Sam came to me. I treat his whole family. I treated him in my previous office at Adventure Orthodontics. You can see he have a super narrow palate. Over here, what I usually look at is I look at the mucogingival junction on a low arch and compare it to it on the upper arch. And if it is wider, I know that's a reference that I use to know that the lower arch is wider than the upper arch. So I don't really look at the teeth or the gum. I look at the mucogingival junction where the soft tissue and the attached gingiva meets, and I do the comparison. And you can see here, if you draw a line up, the bottom jaw is obviously wider than the upper jaw. And that's when I decide, that's how I make my decision to do an expander or not. because sometimes a patient may have a deficiency and it doesn't really show as a crossbite. And I know a lot of people use a posterior crossbite as reference, but a lot of time the patient may not have a crossbite, but they do have a skeletal discrepancy between the upper and the lower arch. So we did an expander on Sam. You can see how we widened the jaw. You can see now how the upper jaw is wider than the lower jaw. So we went from here to there. So he much wider. I actually did an expander on the bottom for him as well. So we did an upper and lower. So the lower jaw, you can't really expand the lower jaw. But what happened is a lot of time when the patient have a narrow upper jaw, the lower teeth will be tipped in. So that lower expander is going to really help upright those lower teeth because the lower jaw is just one piece of bone. This is an example of a patient that is older. What happened is I want to show you guys the different phases of what could happen if the problem go undiagnosed and the patient or the parent doesn't do anything. So you can see Caden is older than Sam. So in a patient with a narrow jaw and with a underbite tendency, this is how they would develop as a patient. And Kaden, I believe, is around like 16 or 15 or 16 here. But at this point, his upper jaw is so deficient. He have a crossbite. You can see the mucogingival junction is much wider than the upper one. He have a big negative overjet here. So at this point, you can no longer do a rapid palatal expander similar to the one I did in Sam, because that would not work. Number one, his suture have is more integrated. They are more tighter. It's not as open as Sam's. Also, the underbite is very severe. So he is borderline MARPE and also surgery in order to fix his upper the maxilla deficiency. This is another example. This is Aaron, another patient of mine, and you can see Aaron is also older than Sam. So in this patient, they have a full dentition. You can see he has an open bite. His cross bite here is causing him to have interference where he's only touching on these teeth only. This is the picture of him biting down all the way. He have an open bite. He actually only touching maybe 2 or 3 points on each side. So his occlusion is very, very bad. So he's super narrow. He got a open bite. He's snoring. He got all the symptom of airway. So this is a patient that you cannot use an RPE on. You have to use a MARPE on. So that's what we did for Aaron. This is his set that show you his skeletal discrepancy and with the open bite here in the front. So this is a standard MSE. It's not a custom MSE. This is basically MARPE 1.0. This is the very first MARPE that came out where there's no customization. These are pre-made, and then the lab basically gonna solder the arm onto here. Aaron had 4 mini screw that is cemented into his jaw, and that's what we're gonna use to expand Aaron to help him with his narrow palate. Okay. And it's another case of someone I wish would have seen me at the age of 7, like Sam, where we could easily have come in there and did an expansion for her and avoid everything that you see here is wrong, right? Her canine is completely blocked out. She has super narrow lower jaw, upper jaw. She has an underbite. She has basically every problem you can see, but these could be easily avoided if the patient would have been screened at 7 or even earlier, and there's some kind of intercepted treatment that could have been done to help Anna. Anna is actually she is actually in high school. I believe she's 14 years old. But for a girl, 14 is considered to be mature. And obviously you can see that she have gone through puberty, so her suture has already closed. So this one, unfortunately, will become a surgical case in order to finish her with an ideal treatment. And this is her set. You can see her lower jaw is very far forward. If I would have treated her, if she came in at 7, she would probably gonna have an expander with a reverse port headgear in order to help expand her upper jaw and also bringing her maxilla forward. in order to help her with her skeletal growth problem. Another example, you can see the patient is gradually getting older and older. And I hope that you can see the progression where Sam, you can see his problem is very slight. And then we got to Aaron, and then we got to Anna, and then now we got to Ethan. So as you can see, as the age get older and the patient doesn't have prevention or treatment, you can see the bite, the problem, the occlusion, the teeth, they're getting worse and worse and worse. In Ethan case, you can see he have a wide open posterior crossbite on the right side. He got a crossbite here on the left side, and it's become a very, very hard case to treat. If you compare this Ethan to Sam, you can see it is a night and day in the level of difficulty that a provider have to treat. At this point, Ethan, I believe he may be closer to 20 or 21. You're looking at a surgical treatment plan and then basically some type of expansion to get his jaw to where he needs to be. But this is, yes, we can treat these, but in the perfect world, we want to prevent these problems from getting this bad in order for the patient to go the least invasive procedure possible. So what is MARPI? So it's just a little bit background of what exactly is MARPI, right? So this is some research. This is from very old. This is called a super screw here they have. You got 4 screw here. And as you turn this screw, you're getting a suture opening here in the middle. And you can see these are the implant that's being placed. And these MARPI, and they are getting better and better every day with the new innovation on material and screw type. It's allow a provider to really expand someone without tipping the teeth out. And it's really how pushing the limit of how old the patient can be and still avoid jaw surgery, where they actually have to split the suture and do a Lafort or Lafort 1 or Lafort 3. So with these MARPI cases, I'm treating patient in their 30 and 40s without having to go through surgery, and we get a nice, beautiful skeletal expansion in the patient. So you can see here in this picture where the suture is closed, and you can see here this little translucency in between. Those are where the suture is open, and those are area of thinner bone because they are new. So they're gonna be thinner and not as thick as these bone on the side. So you can see that this is a true skeletal opening and not just dental tipping from the expansion. So this is a very beautiful case where we get a nice, beautiful suture opening. And when these things, when a suture open, you get a reduction in resistance in the airway, and it's really improved the patient breathing and help them breathe better. So this is a before, and then of course we use the MSE, and then this is the after of someone who had it, and you can tell this patient doesn't need an extraction. Okay, so the MARPI will explain the patient here, and there's gonna be more expansion with the MARPI. It's gonna be more expansion in the front and then less expansion here in the back. That's why a lot of time when patient have the expansion, you get a big gap in the middle of the 2 front teeth. And also you're gonna notice these patient, their cheekbone will get wider, and it will actually, the patient will see the difference in their face. Now, some patient don't like it and some patient will like it, but their cheekbone will get wider. So I always make sure I tell them during the consult, hey, your cheekbone gonna get wider, and you need to make sure that you're okay with that before moving forward with treatment because your face is gonna change. And sometimes if the patient like the face the way it is, it will be a very difficult conversation if you didn't tell them beforehand that your face gonna change, and then they find out after the fact. That's gonna be a very awkward or bad situation. So always warn your patient, hey, if you're gonna do the MARPI, your face is gonna change. Here is 1 week after the expansion. You can see this is the area where the suture is open. And then this is 8 week after the expansion, and you can see how the new bone's being formed and also it's getting calcified. So after the expansion, I usually get it to the width I want, and then I wait for 6 months before I remove the expander because I really want the new bone to calcify and harden all the way before we take out the under. That way it doesn't collapse. We don't lose any of the expansion. Okay. This is another case that we have with the MSE. And you can see here on the copium CT, a nice, beautiful suture opening. And then the patient here is in braces where we can use some of that space to get rid of the crowding and get the canine to be fitted in. Okay, so this is one without, and then this is the expansion, and then this is basically with braces on where we close the space. And at this point, we are leaving it in here. That way the new bone can get calcified and harden. We don't want to remove the marpy right away because the patient will get some loss in expansion. But you can see how he have a crossbite here, and you can see after the expansion, the crossbite is gone. And we really glad that because before MARPI, this one you would have to do a surgical expansion instead of just a regular expander. This is Caitlin, and she actually did not have any airway issue. She came in because she actually have a crossbite, and she is complaining about her front teeth, which is her incisor, because of the way she bite down. It's wearing down her incisor, and she's chipping her teeth. And that's the reason that she came in for us to correct her bite and then do some veneers in order to fix the chipping. She is also a provider, so she is very conscious of the way that her teeth look. And I really want you to see the change in her face. So this is her before. So if you can basically take a photographic memory of what her face looked like because I'm going to show her what she looks like after the MARPI so you can see the facial change. But this is her before photos. She is in a class posterior open bite. She have edge to edge or a little bit of a cross bite here in the front, and she has no airway issue. This is her custom MARPI. So I do custom MARPI now. You can tell the difference between this and the other one, where it's just a perfect rectangular. A custom MARPI will look something like this, where every patient will have a different design. I decided to have 6 implants on her because of her age. She's older, so in order to have a better prognosis, I designed a 6 implant custom MARPI. This is called a tiger screw. It have the expansion of up to 14 millimeters, and that's what we did. It is 3D printed, and I cemented with band lock in order to get the strongest bond. Because the last thing you want is for these to come loose or come out during the expansion because it's very, very hard to fix. This is what Caitlin Marpy looks like. Okay. And you can see the difference between here and here. So this is what it looks like after the screws are in. And you can see after her initial turning, she already start getting some opening. She is, I believe, 39 or 40. So this is really good for expansion in someone who 39 and 40. And you can see there's a little inflammation here. And this is perfectly normal because the suture is opening. So you get some bone generation and some breakdown of the tissue. So this is totally normal. The patient is going to tell you that she's have soreness and pain here, but you just have to reassure the patient to keep the area clean. And this is normal process. That way they don't get freaked out. Okay, so this is Caitlin again, and then this is what she looks like after the expansion. You can see her gap now is a lot bigger. She have a nice wide diastema here. Her crossbite is completely gone. You can see her, she now has, I think she only hitting on a 7 now, on the second molars. So she have a open bite all the way around. This is the expansion. You can see the screws opening here. At this point, we cut out the arm and we leave this here for 6 more months before we remove the expander. And then at this point, we put braces on, and then we're basically going to close the open bite, close the diastema, get her bite ideal and perfect because we have achieved our objective is in getting her crossbite fixed. One of the funny thing is Caitlin came in and I just asked her like, "Hey, Caitlin, I know you didn't have airway issue, but how's your breathing now?" Because a lot of my other airway patient, they'll get the MARPI and it's really helped with their upper airway resistance or their sleep apnea. And she was like, Dr. Bar, you know what? Like, now that you mention it, I felt like before I was breathing through a closet and now I'm breathing through a gymnasium. I'm breathing so much better. And I didn't realize that I could breathe like this. So I like, wow, Caitlin, that's a very big testimonial. Like, would you tell that to everyone? She's like, yes, if you have any patient that wanna talk to me, I'll be their biggest advocate because I'm breathing so much better now, even though I didn't have airway issue. And I think it's kinda eye-opening because I wear glasses, and before I had glasses, like, I didn't realize that I can see things like this sharp, right? So in an airway patient or in just a regular patient, they've been breathing the way they have all their lives. Like Caitlin, like she said, I don't have airway issue, but maybe she did. And now that she know the difference in like, hey, I can breathe like this. What do you mean I can breathe like this? So she can have something to compare to. Now she will tell you like, hey, I would do this again in a heartbeat, even though I had to deal with the pain and the soreness of the expander. She said it was totally worth it. And she have talked to many of my patients about how Marpy have helped her breathing better, in addition to now her bite is much better. Okay. And this is Caitlin here. This may be about 2, 3 months ago. You can see the facial change in her face now. She looked totally different from where she at. Her cheekbone is a lot wider. Her open bite is now closed. Right now, we're just trying to close the rest of her spaces here. She has some spaces here in the front. She was class 3. You can tell now she is more of a class 1. She no longer have any crossbite. She doesn't have any flaring. So she looks really good at this point. Caitlin teeth is very straightforward. We're just gonna do some finishing touch and she's pretty much done with the treatment altogether. All of a sudden, we went from a posterior crossbite case in a 40-year-old to a very straightforward, simple orthodontic case. They're gonna give Caitlin a beautiful result. And of course, she's gonna get these teeth veneers on these because you can see she have wear in her teeth where one tooth is shorter than the others. This case now become very straightforward, very easy, and a very beautiful result. And you can tell her expander is now removed, and she's a happy camper. She's always grinning like this now. She always very happy when she comes in to see us, and we are very happy for Caitlin to be able to have a better, healthier life. So Joseph is a surgical case. So you can see I'm increasing the level of difficulty and the amount of invasiveness that we have to do for patients. So he have an open bite and a tongue thrust. And so he was referred to me, and I'm working with Dr. David Alfie on this case. I just kind of saw him and we're doing clear aligners on him to prep him for surgery. But you can see he had braces before. He came in with the permanent retainers. So I know he had braces before. According to him, he didn't have an open bite when he finished with his treatment. So that led me to believe that the open bite is caused by a habit, and more than likely is the tongue, because you can see how his teeth is flared out. The tongue is right here, so more than likely his open bite is caused by a tongue habit that's require myofunctional therapy in order to prevent him from relapsing. He have a midline deviation, he have a cant in his jaw, and he have a class 2 on the left side and a class 1 on the right side. He not as difficult as Anna, but this is a case of an adult who have a habit that wasn't recognized by the dentist or the orthodontist, so it was never talked about, so the habit was never fixed. So even though he had braces and his occlusion was perfect when his braces are off, you can see his malocclusion came back. Joseph isn't an old guy, right? He's probably in his 20s sometime, and he already relapsing this bad. So I know if we not getting his tongue fixed and not getting everything corrected, this will happen again in the near future for Joseph. We treated him. This is a video of us. He was in treatment for about a year in clear aligners, and I basically set up his teeth to where it need to be. We referred to Dr. David Alfie. He's here in Houston, and this is a session where he and I, very similar to DSD, Digital Smile Design, where we design where his jaw is going to be, upper and lower jaw. We check his occlusion to make sure the bite is where I'm happy with. We did clockwise rotation of the mandible, counterclockwise rotation of the maxilla to make sure everything the way it is before we approve it for surgery. After we approve it for surgery, so this is pretty much where we're happy with. So, you can see, we can see where his teeth's gonna be after the surgery. And that way, when I see him again, I just have to do some finishing with the clear aligners in order to get his jaw to the way they are. And he's a young patient that I've seen during the COVID period, but his testimonial is pretty powerful. And again, I want to finish off what I said at the beginning is pediatric intervention is where it needs to be. That way we can prevent the need for MARPI and surgery altogether.
Hey, Mom and Britton. You've been in treatment with us for about 8 months. So, Mom, why don't you tell us about the issue that he was having before getting treatment here?
So we initially came here because Britain's teeth were crooked. And as I've sat and talked with Dr. Barr about the issues of him snoring and not sleeping through the night, and he immediately recognized that there could be an airway issue. He suggested that the treatment plan would be the expander. And 8 months later, he's sleeping through the night, no more snoring, which I love. And I mean, it was a great decision. And it felt really good. Now I really sleep through the night.
And you talk a little bit about how he's not going to your room anymore.
Because he sleeps through the night, he is no longer going to my room, which we all appreciate.
And talk a little bit more about, I know you mentioned he kind of toss and churn at night.
Yeah, he was tossing and turning and again waking up when, yeah, because he was snoring again, which I didn't put all of this together until you mentioned that we could have an airway issue. And we had had his tonsils removed, his adenoids removed. We had did everything else that other doctors had mentioned. No one else had mentioned anything about his airway until we came here, and we're very thankful that we got it done.
And would you say the expander, after we put it on, it helped you almost right away and you see a big improvement in your snoring? Will you say that happened almost immediately?
Yeah, it helped me really a lot. I can vouch for the snoring. Yeah, I mean, it dramatically was reduced after that. Okay, like,
Okay, awesome. Well, thank you guys.
Hey, so I really believe if we can teach the parents to recognize these symptoms, we can really help our children because they can't help themselves. They won't know. And we can avoid patients like Ethan and Anna and Aaron, where they need morphine and surgery, or like Joseph. If you tell a parent, hey, if you do this now when he's 7, and you don't have to do an $80,000 double jaw surgery later on, which one will you pick? And then I think any parent will pick the regular RPE in phase 1 and not to do the surgery. So that is the end of my presentation, and I guess I have time for some questions.
Yeah. Hey, Dr. Bars. So good job. That was awesome. There's a question in the chat. Does it help you breathe through your nose better as well?
With the
That was
expander
asked during Caitlin's.
case, yes, so Caitlin case is breathing better through the nose. So we always advise to breathe through your nose. There's no mouth breathing. And we say this a lot, the mouth for eating and the nose for breathing. So the breathing, the improvement in breathing is through the nose. What she said, I used to breathe through a closet and now it's through a gymnasium. And she actually posted that on her Instagram, the quote.
What age would you recommend to take their kids to get screened by an airway orthodontist?
Most of the time, I spend most of my time educating the general dentist or the pediatric dentist because they're gonna see the patient much younger than I will, right? So the pediatric may see them at 1, general dentist see patient maybe at 1 as well. So they're gonna recognize these symptoms if I teach them well. The AAO recommend the age of 7 because the permanent first molar will be fully erupted. But I know I have treated some patient younger than that in special circumstances because the GP will refer to me earlier because they'll recognize a crossbite or they recognize an asymmetrical jaw growth that cause a deviation in the growth. So really, I recommend for the GP and the pediatric dentist to work with their local orthodontist and look for these symptom, and I believe the earlier the better. And a lot of time, my screening, I don't charge for them. So a screening is really quick. I take a panoramic X-ray, look in the mouth, and if there's nothing, then I'll see them in a year, 2 year, 3 years. So I would recommend the sooner the better. And a lot of time, the patient I see, they'll say stuff like, "Hey, when I was their age, I don't get braces until 13." And I'm like, well, it's 2026, we know better now, right? They always compare it to when they have braces. So I tell them the sooner the better because these things we deal with skeletal and not dental.
Yeah, that's awesome. I know that a lot of people are wondering if their kid is ready to see, and you had put together a really awesome quiz that they can take to find out if they need to come see an orthodontist. So I'm going to put that into the chat for everybody So you
Yeah.
guys can click on that to take it. Dr. Barr, I also put your contact information in there for them, the phone number to the practice and the website for anybody who wants to reach out and schedule a consult. And I know not everybody here is local. So if they wanted to look into an orthodontist near them, do you have any like questions that they should ask to make sure that that orthodontist also can look at their child's airway or their own airway?
Yeah, so the assessment was really helpful. I made that assessment, I believe it's 7 question, and if you answer it, it'll give you a score, and the better the score, it'll tell you, "Hey, you scored this." That mean you don't need to see an orthodontist, but the worse the score, it'll tell you, "Hey, you need to schedule a consultation." So when you take that test and it'll tell you, let's say, for example, "Hey, you need to see an orthodontist, and you're not local here," then I would reach out to that orthodontist office and said, "Hey," depending on what you put onto the test, it will say something. But let's say it would say, "Hey, your child may have airway symptom." You can put that into the reason for your appointment, right? So it will say, "Hey, I have airway issue," or "My child may have airway symptom." And a lot of time, the office who is airway oriented, they will know exactly what to do. So most of the time, the office that not airway oriented will say like, "Hey, he's too early," he'll grow out of it, or he will say stuff like, "Hey, if your tonsil is big, you just need to get some what you call it." Some anti-allergy medication. So they'll say stuff like that. But for an airway focused orthodontist office, they'll ask you different questions. They're like, "Hey, is your child snoring at night? Have you got a sleep test? Have you take home sleep test? Who's your ENT?" So they'll ask, do they mouth breathe or suck their thumb? So the question that they'll ask you is going to be an indication of if the practice is airway focused. So there's no such thing as airway orthodontics because it's not a recognized specialty with the ADA, but most of the time for my practice, I tell patient I'm airway focused and not really airway orthodontics.
Would you recommend someone with TMJ to see an orthodontist? I know this is a different field, but I thought I would ask. Also, would you be able to tell if a person is losing part of their jaw or misaligned?
Losing. Okay, let's address TMJ and the TMJ. So TMJ is a multifactorial problem. And just like Airway, you need a team to help you diagnose and treat TMJ. Usually, you have a TMJ specialist that make a diagnosis of what is the root cause of the TMJ problem. And if the root cause of the TMJ problem dealing with the occlusion, then the orthodontist can help. But if the TMJ is caused by the joint, I know there are people who have arthritis who have TMJ issue, or there's people who have trauma that will cause the joint to be dislocated. That means the problem is with the joint and not with the bite. So the orthodontist, doesn't matter how perfect the occlusion or the bite is, your TMJ problem will not go away. So that addressed the TMJ issue. So the TMJ, you have to find out what is the cause of the TMJ. And if it is the occlusion and the bite, then the orthodontist will have a place in fixing that. But if it's not, then there's no point of going to the orthodontist. And then the other question was, I'm not sure what it mean about missing the joint, but if the jaw is misaligned, then the orthodontist can diagnose for you to see if the jaw misalignment is due to a skeletal problem or a dental problem. If it's a dental problem, then we can fix it with just braces or Invisalign. If it is a skeletal problem, then you will need surgery.
Hi, everyone. Thank you so much. I just finished with surgery and jumped on the webinar. I would like to chime in a little bit on that questions too, because we get that questions a lot in our new patient exam. And actually today we have a patient came in. He just got Botox done because the TMJ issue was so bad. And of course, we don't want to use neurotoxin to just address the symptom. So in his case, and in a lot of patient case with the TMJ disorder, the jaw joint disorder, if you want to call that, then the number one issue that underlining we call root cause is actually oxygen deficiency. Like Dr. Barr mentions earlier, without the home sleep test, without a proper diagnosis, we can't call obstructive sleep apnea yet because we don't know what kind of obstruction they have, right? Is that mild? Is that moderate? Is that severe? Is that an upper airway resistance syndrome? However, we know these patients have a huge issues with elevated CO2 level and really low level of oxygen, especially during the night. The heart rate go up, the cortisol is elevated, and they're not getting enough REM and deep sleep. And therefore, that turn into a lot of different symptoms. Like a lot of patients, that's a jaw joy because the jaw actually working harder, clenching, grinding, try to open up the nasal space to get more oxygen in. Then there's people that have pain on the leg or twitching or restless leg syndrome. Then there's people that are having a lot of gut issue because they're not able to detox. And so there's could be a lot of variety of different symptoms, but one of the major root cause that we see in every patient coming in is we always have to evaluate, are they breathing through their nose? Are they having enough room to breathe? And do they engaging the diaphragm and the belly breathing or just chest breathing? And then are they having any sleep tests? Anyone evaluated them? The patient I saw today, I'm the provider number 26. He's in 25 different providers in the last 12 months. And so imagine the frustration. His wife was crying. He was crying because they felt hopeless. And so the first thing you want to check is, of course, like Dr. Mar mentioned, are you breathing through your nose? Are you closing your mouth at night when you're sleeping? Have you get anyone look at your sleep test? And regardless, you're 72 years old or you're 22 years old, and a lot of time these young patients, we call high performer, they get overlooked, right? They're thinner, they're not having a belly, they don't have a big neck. So most of the providers don't even ask about airway evaluations or home sleep tests. And so majority of the patients that have TMJ disorder or TMD have issue with airway, have issue with sleep apnea or deficiency of oxygen. So the first thing I want to make sure that you are checking it there, screen it there, and then eliminate that. And you'll be surprised to find out how many of these patients actually dealing with that issues since they were young, right? Combination with tongue tie, combinations with loss of ear infections, and all of this issue when they were younger, but they never make the connections. And so working with a team like Dr. Barr, working with ENT, working with a lot of different specialists in medical and dental field really bring the picture together. So I hope that helped to get everyone a bigger pictures of not just a symptom, but actually one of the major root cause we see in all our patients. Let me see what the next question here is, Dr. Barr. The next question here from Tony, oral myofunctional therapist here. Hello, we love to have other healthcare professionals on here. How important is myo in your opinion? Absolutely. I wish every patient's willing to commit to do myofunctional therapy. And like obstructive sleep apneas or oxygen deficiency, all of our patients who doesn't have a proper swallowing, breathing, and tongue position all have different symptoms also. A lot of people have anxiety, right? Their tongue is not in their mouth. They are not breathing through their nose or through their, using their belly and diaphragm. So I would say having an oral myofunctional therapist in the office, everyone should have that evaluated, and your dentist, your wellness dentist, should incorporate that into your evaluations. And then working with a myofunctional therapist, when you're ready, willing to commit to do exercise, willing to spend the time to build a new habit, it's not just for your tongue and your mouth and your expansion, but also for your emotional, mental, and physical health. So I'm a big fan of all my myofunctional therapy, and my son actually is going through his myofunctional therapies right now. So highly, highly recommend to get evaluated. The key thing is you have to do the exercise, because otherwise your therapist is going to be very disappointed that you don't get the new habit and the new benefit because you're not getting that muscle memory built into that new position. Dr. Ba, anything adding on oral myofunctional therapy? Because I know you work with a lot of
Yeah,
cases.
you do a lot of mouth therapists.
Yes,
Yeah, I have at least 6 that I refer to.
yes. And you work with cases like tongue thrust, right? And expansion cases,
Yeah,
because it's
tongue touch is
impacting
one,
the longevity of the result of the case.
a lot of tongue tie.
Yeah. And patient asked me, how come I had braces done not one, but twice, and sometimes 3 times, and my teeth shifted, or basically we call relapse. It's because the improper swallowing, right? Because the tongue position is not correct. And so if you work on oral myofunctional therapy, then that relapse is less likely to happen. The next questions on that, Dr. Barr, is what's your thought on night guard for adult to prevent wearing out teeth from grinding? What I see with when patients come in, and I have to say 9 out of 10 patients that come in to see us would have like gar, not one, sometimes multiple gars. And they have very similar design, which is on one arch, either on the top or the bottom, mostly on top. And it's like a one size fit all, which means all the teeth are touching. It is custom made to your jaw, but you're touching from the back and the front, and it's one arch only, which is only on the top, on the bottom. So what we notice is my questions when I see patients that have grinding, patients that have GAR prescribed and made for them, my question is, have you got your sleep test done? Have you seen an ENT? Can you breathe through your nose? Because giving someone grinding a GAR is like telling someone that, you have cavity, just floss and brush. That's going to work. Not checking the blood work for vitamin D level, not checking if they're breathing through their nose, not checking if they having nutritions and hydrations and all this and their sleep. So my point is, if you're grinding your teeth, yes, something needs to be done, not just the GAR, but understand what proper design of an appliance. Sometimes you need more than just the GAR. Sometimes you're going to need to address the root cause. So I have patients come in with that kind of GAR and they grind through it. They had a hole in the GAR. And my question for them is, where does plastic go? They literally eat it, right? And so my point is, if you grinding and give you a GAR and you grind through that GAR, that means it's not the solution. It's a Band-Aid. So whenever you was given a GAR, you have to ask the question, is this GAR is the right design for me? Do I have underlying issues that I need to address instead of just put the Band-Aid on? Now, if you get the GAR, wearing the GAR, and continue working on those underlying issues, great. But don't just get the GAR and thinking, I've done enough. You have to ask more questions because grinding is a symptom of your body telling you, I need help. Okay. The next question is, if a 9-year-old child snores badly, should he see an orthodontist or get a sleep study for sleep apnea? Dr. Barr, I'm going to have you answer this first.
Sure, yeah, that's an easy question. Sleep study first. That's an easy question. I would do a sleep studies first because that's another thing I need to mention. A airway focused ortho office is gonna know how to read the sleep test, and they can
Yeah.
explain. I mean, I know the person who prescribed the sleep test need to go over that with you, but they'll know how to read it. So if you come in and said, "Hey, my child has sleep problem. Here's the sleep test," they'll take you more seriously because they'll know, oh, this person do the homework. I'm gonna read the sleep test. I know exactly what the problem is, and that will really help the orthodontist know exactly what treatment to prescribe for that child.
Yes. And usually for a 9-year-old, if you have a very forward thinking pediatrician, yes, they will talk about it and they will prescribe it. But most likely that's from an ENT, pediatric ENT. It's most likely done in a hospital setting. So whenever you're having a sleep study done, there's much more information than just about oxygen. It's sleep positions, it's also brain wave, a lot of different things that consider. And so you want to make sure that you work with the right provider. And I guarantee you, a forward thinking ENT will also have orthodontists that they work with and they can connect you with. And like Dr. Barr said, if you show up at Dr. Barr Orthodontics and you're having this sleep study, now his approach is a lot more personalized and a lot more, I would say, age and urgency appropriate because now we know this child really need help. And on top of that, we like to be able to follow up, right? When a patient in my practice having home sleep tests and they end up getting, say, an ENT treatment with ENT for deviate septum, and we do follow-up sleep tests, we actually see the significant improvement on their numbers. And then on top of that, they do oral myofunctional therapy. Then we also seeing significant improvement on that. So have a baseline is really helpful for us to know if that therapy or that treatment working and how well it's work. So I really like the fact that you have data and have a proper diagnosis, no matter that patient is 9-year-old or 39 years old. The next question we have, Dr. Barr, is how would I get a sleep apnea test? Do I ask my primary care physicians to have a sleep apnea test? Yes. If you see a functional medicine provider, they also can provide you a home sleep test. The key thing is who's going to read your test after the test was done, right? Usually, home sleep tests will come with a report, and you're going to sit down with your provider, that an ENT or your orthodontist or your wellness dentist. You want to understand that report, and that come with a lot of different modality and therapy that available. For example, in our home sleep test report, our patient giving an options of working with an orthodontist, working with an ENT, working with an oral surgeon, working with an oral myofunctional therapist, getting laser therapy for snoring called a night laze, doing weight management to make sure that would help with getting more oxygen. So all of this on your report will give you options. And then together with your provider, you decide which one is the best step forward for you. And so it's had to be personalized. And so the sleep test, you definitely can ask your dentist and your ENT, like Dr. Barr said, and also your primary care provider. They usually will give you a questionnaire, right? And then you answer the questionnaire. And then based on the score, they will see if you qualify for a sleep test if you're going through, say, medical insurance. So make sure that you communicate and ask your dentist, your ENT, and your primary care provider. Remember, Dr. Barr and I both on social. You can always send direct message or DM on Instagram and message on Facebook if you have more questions after this session. And next week is really exciting because we got a lot of questions in our messengers and our DM about saliva testing, about periodontal health, like bone loss. Today, there's a questions earlier that I heard about bone loss. And so our biological hygienist, Laura Vargas, is going to be on this webinar next week at 6 p.m. Central. And we will send out our registrations for that she's going to discuss about everything about wellness perio, which is wellness gum health, bone health, and how do we keep our teeth longer and what can we do at home as well as in the office together with your wellness dentist to really keep your teeth for life. So make sure you tune in for next Wednesday at 6 p.m. Central. Thank you, Dr. Barr. Appreciate that. And please send us more questions, and then we will see you guys next week.
Good night, everybody.
Good night, everyone.
Bye.